the use of checkpoint inhibitors in stage 3 disease is meant to be curative, although we don't cure 100% of the patients. I think one of the important questions is, can you go back to using checkpoint inhibitors if patients do progress to stage 4 metastatic disease? It is currently a data-free zone. We don't have any information. The use of checkpoint inhibitors in stage 3 disease is a relatively recent phenomenon, which we'll discuss today. And I think many of us are wondering about those patients who may relapse. Can you use this data that we typically use in stage 4 disease, the data from Keynote 189, Empower 150, Keynote 407, in other trials? Over the past couple of years, we've seen a myriad of trials in stage 4 disease that have really solidified the use of checkpoint inhibitors in stage 4 disease. But all of those patients were naive to checkpoint inhibition prior to those trials. So I think as a general guideline in practice today, how I would think about it is the issue of timing. If someone has a relatively long disease-free interval, and I would say at least 12 months from the time that they had received a checkpoint inhibitor, that I would tend to go back to a checkpoint inhibitor in that particular setting. If someone progressed to stage 4 while they were on a checkpoint inhibitor for stage 3 disease, that would tell me that there's some inherent resistance to checkpoint inhibition, and I wouldn't be optimistic that a different checkpoint inhibitor at that point would have much clinical utility. However, I will point out that we don't have clinical data at this point to support one argument or the other, and it's really a very unmet need at this point to generate some of that data so clinicians know what to do. In stage 3 disease, we typically do test for those patients, and I think the reason that we test for those people or test those people is because many of them historically have developed stage 4 disease. So you would want to have that information if they were to transition from stage 3 to stage 4 disease, because that would impact your treatment decision. The reality with current standards of care and current guidelines is that in stage 3 disease, we don't necessarily know the significance of what to do with an EGFR mutation or an ALK translocation or ROS1 or BRAF or any of these things that we typically test for. We don't have established paradigms based on phase 3 trials that would tell us that we should treat differently based upon these molecular findings. Now, that is totally opposite in stage 4 disease, where we know that if you have an EGFR mutation, using one of the EGFR TKIs is superior to chemotherapy. ALK-directed therapy in ALK translocated patients is superior to chemotherapy. So in stage 4 disease, it really impacts how you manage the patient. We don't yet have information from randomized trials, many of them are ongoing at the current time, about how to use the molecular markers to alter therapeutic approaches in stage 3 disease. And I would also make the argument we don't have established paradigms in the surgical setting where you've had curative resection with surgery. Typically, those are stage 1 or 2 patients. Let's say you find an EGFR mutation in a patient with stage 1 adenocarcinoma of the lung. We would give that patient adjuvant chemotherapy. We don't yet know the role of EGFR TKI-directed therapy in that population. There are ongoing studies that are hoping to define that, but currently in 2019, it shouldn't impact your management in stage 1, 2, or 3 disease.